Good morning, good afternoon, good evening. Hi, everyone. Thanks for joining our Living Evidence Network State of the Science webinar. Today we'll be talking about living network meta-analysis. My name's Tari Turner. I'm from Cochrane, Australia, based in Melbourne, and it's my privilege to be facilitating today. We'll give everybody a couple of minutes to join us and then we'll kick off. I'll be back in touch in just a couple of minutes. Hi, everyone. Thanks again for joining us for this Living Evidence Network State of the Science webinar. My name's Tari Turner, and it's a great pleasure to welcome you. We're just going to wait 1 or 2 more minutes for more people to join us. I can see already that there are 33 people online. A great diversity of people I know have put up their hands to RSVP too. So we'll give them just a couple of more minutes to jump from their other meetings and come across to this one, and then we'll kick off formally. I feel like we should probably have some music on in the background just to reassure you that your sound is working. Just 1 more minute and then we'll commence our presentations. Okay, great. Thanks very much for your patience and for your timely arrival at our webinar this morning, this afternoon, or this evening, depending where you are. It's great to have you on board. As I mentioned, my name's Tari Turner. I'm a Senior Research Fellow at Cochrane, Australia, based at Monash University, where I work with Julian Elliott and Joe Brooker on living systematic reviews. It's our great pleasure this evening to host this Living Evidence Network State of the Science webinar looking at living network meta-analysis. We've had more than 110 people RSVP for this evening's session, so we're really excited that you're as excited as we are about finding out more about living network meta-analysis. We have 2 great presenters this morning, or this afternoon, depending where you are. We have Dr. Anna Kaimani, who's a Senior Research Fellow at the Research Centre of Epidemiology and Statistics at Paris Descartes University. She's a co-convener of the Cochrane Statistical Methods Group and the Cochrane Comparing Multiple Interventions Methods Group. She's worked across several areas in network meta-analysis, such as small study effects, software development, presentation and reporting of results, and of course, most recently, living network meta-analysis. And she'll give us a bit more background on her work when she presents in just a few moments. But it's fair to say that we're delighted that somebody with her skills and experience can present to us this evening, or this morning, or this afternoon. Anna will present for 15 or 20 minutes, giving us an overview of what living network meta-analysis are and the key things to consider in conducting living network meta-analyses. Then we'll have a presentation from Dr. Sam Whittle. Sam's a Senior Consultant Rheumatologist at the Queen Elizabeth Hospital in Adelaide, South Australia, and a Senior Lecturer at the University of Adelaide. He's part of the ANZMUSC, Australia and New Zealand Musculoskeletal Clinical Trials Network, where he's a practitioner fellow looking at living evidence. He's also formerly a board member of the Australian Rheumatology Association and has volunteered to be our discussant this evening. Sam's involved in a large body of work around living systematic reviews and living network meta-analysis that is about to kick off, and he's going to give us a description of his work and ask some pertinent questions for Anna, the kinds of questions that we all might be considering if we were about to launch into a living network meta-analysis. After Sam's presentation, we'll then have an opportunity, Anna will respond to his questions and we'll have an opportunity to ask questions of our own. After each presentation, I'll wait for a few minutes for questions for clarification, but we'll hold questions for discussion for after the two presentations, where I'll open the floor to you. We'll have plenty of time for discussion, so I'm looking forward to that. Without further ado, I'm going to hand over to Dr. Anna Karmani, who will tell us a bit more about her work and give us an introduction to living network meta-analysis. Thanks very much, Anna.
Thank you for the introduction, Dari. And I have to say I'm quite new in the field of living network meta-analysis. I have done a lot of work in the field of network meta-analysis, where I did also my PhD. But I started working on living network meta-analysis within the last year, and I realized there are several methodological issues to resolve. So I will start today with an introduction to network meta-analysis, just to make sure that we all understand the concepts and the assumptions and what is the aim of a network meta-analysis. And then I will continue with describing an example of a living network meta-analysis that we are currently working on, which I think it's a quite interesting example. Then I will discuss a little bit what challenges we have encountered in the process of conducting living network meta-analysis, and finally I will briefly outline what is our future work on the field. So first, why do we need to do network meta-analysis? Why pairwise meta-analysis are not sufficient? So I will take an example from the field of antidepressants, where we know that there are every year there are new drugs coming on. So before the first network meta-analysis was published in the field, there were many different pairwise meta-analyses. And they had conclusions like, although mirtazapine is likely to have a faster onset of action than sertraline and paroxetine, no significant differences were observed. Then another meta-analysis compared sertraline with fluoxetine. And then there was another one comparing fluoxetine with venlafaxine. Another meta-analysis concluded that venlafaxine tends to have a favorable trend in response rates compared with duloxetine, and so on. So its meta-analysis was comparing only two drugs. And finally, if we look all these different results from different meta-analyses, we don't know which are the best drugs to select. So we get puzzled at the end. We don't know what to do. So network meta-analysis is based on the concept of indirect comparisons and mixed comparisons. So let's say we have studies that compare directly a treatment B with placebo and a treatment A with placebo. So the idea is that we can obtain an indirect effect between A and B via placebo. So we can combine the studies comparing B and placebo and the studies that compare A and placebo to indirectly compare treatments A and B. And then if we also have a direct effect for these two treatments, we can combine them to obtain what we call a mixed effect. So the mixed effect is a combination of the indirect and the direct effect, and in fact, it's a weighted average of the two sources of evidence. So we can extend this idea to the case that we have a full network of interventions. And in such a case, if we combine the results of all these trials, we can answer questions like, which are the most appropriate treatments to recommend, for which population and under which setting. And so this is a much more important and interesting question in comparison to questions for the relative effects between only 2 treatments. So the difference between a full network of interventions and the case with only 3 treatments is that here we have several sources of indirect evidence. So for example, if we focus again to the comparison between treatment A and B, we can obtain indirect effects via treatment D, for example, also via treatment E, or via treatment E and placebo, and via many other routes. And so the full network meta-analysis model combines all the different indirect comparisons with the direct in order to obtain what we call the network effect for every comparison. And of course, we do not do this by hand, as we can do it when we have only 3 treatments, and we need more sophisticated methods to run this analysis. I'm not going to talk about the statistics of the method. And once we run the full network meta-analysis, we can obtain a table like that, where we have, here are the competing treatments in the network, and here each cell contains a relative effect between the treatment in the column and the treatment in the row. And so we can see that we can obtain a relative effect for any pair of treatments, even for those that they have not been compared in any study. And then the question is, are these results reliable? So as with any statistical analysis, there are assumptions behind. So the results are as reliable as plausible are the assumptions that underlie the analysis. And the main assumption of network meta-analysis is the assumption about direct comparisons. So there is one single assumption which has two aspects. It has the conceptual aspect, which is called usually transitivity assumption, and the manifestation of the assumption to the data is called coherence or consistency. So I will not give more details about that. I will just I will describe briefly how we can evaluate this assumption, which is very important. So before we obtain the data, what we have to think in order transitivity assumption to be plausible is whether treatments are jointly randomizable. So this means that we should be able to consider a big randomized trial, which in theory could include all the treatments in the network. Of course, in practice, this is not possible, but theoretically, this would be a meaningful thing to do. And this is how we should define the inclusion criteria for treatments, studies, and populations. And then, once we have the data, we should check whether the population and study characteristics, whether they are similar across the different comparisons. And we should focus, when I say characteristics, we should focus on the effect modifiers. So we should check whether the effect modifiers are similar across the different comparisons in our network. And finally, when we get the data, Finally, when we get the data, we should test the coherence assumption. So we should check whether direct and indirect evidence are in agreement. And there are several tests, statistical tests to do that. So I will move on now to the example of a linear network meta-analysis. And that was an example about second-line treatments for advanced non-small cell lung cancer. So here we can see the network diagram, and it has 58 treatments, so it is a very large network. It has 92 trials and almost 32,500 patients. And before this network was published, there were 29 systematic reviews describing partially this data. And so these systematic reviews were published mainly between 2009 and 2015. And we can see how then, if we consider the systematic reviews of 2009, how the network was formed, and then how it evolved up to 2015. And all these systematic reviews were always incomplete, so only 40 to 66% of the treatments, 40 to 66% of the treatments were missing on average, and 45 to 70% of the trials were missing, and 30 to 58% of the patients were missing. So none of the systematic reviews was able to include all the evidence. So we started to work on this network as a living network meta-analysis. So what is the living network meta-analysis concept? We have an initial network of trials, and we do all the analysis, we do the data extraction, and we check the assumptions, and we interpret the results. So then, after some time, so this depends on the investigators on the field and on several other things. We move on to the next iteration. So this means that we should first consider whether there are new treatments for the condition that we investigate, and based on that, we should update the search. So if there are new treatments that we already know, we should update the search to be able to identify these new treatments. And then we continue with the selection of the trials based on the inclusion criteria that we had for the initial network. We extract the data. We need to assess again the risk of bias data. And then we need to do again all the analysis, all the synthesis, and to interpret the results. So here we have estimated on average the workload for each iteration for the lung cancer example, and in red we have the workload for the initial NMA, and in green for each iteration. So we can see that the initial NMA had 45 treatments. And we estimated that at each iteration, which was defined to be every 4 months, we will have on average 2 new treatments. So it's a field that evolves very fast. And also at the beginning, we had 8,000 records to screen. And at each iteration, we would have about 380 records, which is about 5% of the initial records. And also we will have on average 4 eligible trials for which we will have to extract data. So we can see that we have invested a massive amount of resources to produce the initial NMA, so it doesn't make sense not to maintain this network meta-analysis, because we waste all the work we had done at the beginning. It is important to say, though, that this is only about the systematic review process, because when we go into the statistical analysis part, the workload it's the same at each iteration, because even if one new trial enters the network, all the analysis need to be done from the beginning. And again, we should consider how to interpret the results if there are important changes. Now, which are the issues that we have encountered in this network? So, first of all, sometimes the initial research question might become outdated over time. So, for example, for the lung cancer network, now most new trials focus on first-line treatments and not that much on second-line treatments, and they consider mainly patient biomarkers. So, so it is possible that after some time, the research question of our initial network meta-analysis will not be so interesting. Also, what we have seen is that when we add new treatments, there might be issues in the network. And we know that when we add new treatments, the validity of the assumptions might be threatened. So we have, at each iteration, we have to check again whether transitivity is plausible, whether coherence is plausible. And very often we identify new treatments which have been evaluated only in one trial, and they are weakly connected to the rest of the network. For example, treatments that are connected only with placebo. And if you remember the network diagram for the lung cancer example, we had many such treatments only connected with one reference treatment. And as we add treatments like that, then the uncertainty of the results increases. And that's a problem because they introduce heterogeneity in the network, and they might introduce also incoherence. And so the results might become less precise than before. So we cannot exploit the fact that we introduce more information in the network, and we lose precision. Then another question is how to exploit any type of formation within the NMA framework. So particularly for such networks with sparse data, it is important to consider what other information might be useful to introduce in our analysis, such as data from other type of studies, non-randomized studies, data from electronic databases, data from clinical experience, and so on. And then one other question is that we have and we are trying to resolve is how to decide whether we need to exclude some treatments from the network. For example, in the lung cancer network, we have many old treatments that we know that they are not of interest anymore, and we know that people do not use them in clinical practice. So, so we consider whether we should keep these treatments in the network or we should exclude them. So these are the main issues that we have encountered in our work. So and all these questions are very difficult to answer, and that's why it is very important when starting a living network meta-analysis to build a whole research community. So these are questions that are difficult to be answered by a single investigator or a small team of investigators, and therefore it is very important to build a research community that will maintain all the living network meta-analysis. And in fact, the research community should be built for a whole condition, not for only one network meta-analysis, but for a whole condition. And it should include systematic reviewers, clinicians, trialists, methodologists, statisticians, and guideline experts, because the final aim at the end is to be able to inform the guidelines using the living network meta-analysis. And also we could exploit this research community in order to improve the production of evidence in general, so to produce better trials and more focus to the questions that have not been answered before. So I will outline very briefly the fields that we're working on now. So this is a new living network meta-analysis that we have started working. We have published the first, the initial network meta-analysis, and here we have the network diagram and the results. These are treatments for chronic plaque psoriasis, and we can see that almost all treatments are much better than placebo, but there are small differences between the different active drugs. But we can see on the left that most active drugs have not been compared with many other active drugs. They have mainly been compared only with placebo. And so this is a field that the living network meta-analysis is very important, because we expect new trials to compare different drugs directly. And here we have the ranking results. So we can see that the treatment which seems to have the best compromise between safety and efficacy is certolizumab, which is, if you see here, it's a treatment which has been compared only to placebo, and actually with the trial was a very small trial, so we don't know if the results are reliable or not. They might be, but we need more evidence to come in order to confirm whether these results should be considered in practice. And in terms of methodological work, when we are trying to answer the questions I explained before. So we are trying to develop formal statistical and non-statistical criteria upon the inclusion and exclusion of treatments at each iteration. So we want to build a decision tool to help researchers decide when treatments should be excluded. And for this purpose, we consider the trade-off between increasing the amount of data and threatening the assumption of the analysis. So we are trying to find the optimal point in this trade-off relationship. And we are also developing methods that allow to share information across networks and to incorporate information from external evidence. So we are trying to share information across networks with similar characteristics, for example, different types of studies or different subgroups. So these results might be correlated, and we want to exploit this correlation to inform networks that have weak evidence. Because networks with sparse data sometimes they are not very useful, and they fail to provide useful and meaningful results, because if there is a lot of uncertainty in the network, then we cannot inform clinical practice. Another interesting question that we are working on is how new evidence can affect the results of the existing evidence, and whether results can change. And this is important because one question is when we should stop continuing with a living network meta-analysis. So it is possible that if the results cannot change easily, we might not need to continue. And I will finish with our website, which is actually a website we are currently building. So there's not a lot of material in it, but we hope that soon we will have much more applied and methodological work in it. And here I have some references. So that's it from me. Thank you very much for your attention.
Thank you, Anna. That was fabulous. A really great introduction to an incredibly complex area of work, and much work still to be around those methodological questions. Very helpful to see a couple of practical examples of the work that you're doing, and to get some insight into the amount of work that's involved in doing these big LNMAs. I can see that there are a few people who've put questions in the question box. Those look to me not so much as questions for clarification but more as discussion questions. So with your permission, I'll hold those over until after Sam's presentation. If anybody does have any quick questions of clarification, and I'm sure Anna would happily take those now, otherwise we'll move on. Let me just make sure I have the questions in front of me. Okay. No immediate questions for clarification, so we will definitely come back to those questions. And we will come back and answer those in a few minutes, but thank you for those questions. There's some really great conversation starters there. Sam, I'll hand over to you. It'd be great to hear more about what you're doing, and then to hear about what questions you have too.
Great. Thanks, Tari, and thanks, Anna. That was a really fascinating presentation, and there's a lot for me to think about there. So thank you for the opportunity to present to you all tonight from down here in Adelaide, where it is currently the evening. I just want to start by presenting a couple of caveats. Firstly, that we're at the very early stage of planning our living NMA for rheumatoid arthritis, and I'll talk you through some of our thinking. So we certainly don't really have many answers to provide, but we are generating lots of questions. So hopefully the issues that we're grappling with, and they're similar to the ones that Anna's already discussed, will provide quite a good catalyst for discussion today and into the future. And secondly, this is a collaborative effort that we're working on, and the vast majority of the work that's been done so far has been done by Glenn Hazelwood in Canada. And these are mostly his slides, and it's mostly his work that I'm presenting. So I just want to acknowledge the huge amount of work that he's doing as part of our collaboration. So we are planning a living network meta-analysis of treatments for rheumatoid arthritis. And briefly, here's the rationale for why we think that this is an appropriate method to undertake for this condition. So rheumatoid arthritis, we know, is common, and it's got a high burden of disease in terms of pain, disability, and quality of life. And over the last 20 years or so, in our specialty, we've seen an explosion in the number of available medications to treat rheumatoid arthritis. But and prior to that, really, there were no or few effective therapies. And now we've got numerous effective therapies, which go by the slightly awkward acronym of DMARDs. And we know that these are, in general, effective. For the previous several decades, before really the turn of the century, we had so-called synthetic or traditional DMARDs, and in the last 20 years, we've had a whole lot of new drugs, which are generally grouped under the heading of biologic DMARDs or biologics. And so now we've got a large number of treatments to choose from, but there hasn't been a lot of comparative effectiveness research in terms of direct comparisons of DMARDs. And we're continuing to see new drugs emerging. So having this array of options makes a network meta-analysis attractive, and in particular, taking a living approach to this is important for rheumatoid arthritis due to the rapidly evolving evidence base and the high burden of disease. So in order to provide really high quality evidence syntheses for consumers and their caregivers to make decisions about RA, we think that a living NMA would be a good way to assist in that. And we are hoping to translate the work of this living NMA into the basis of a living treatment guideline, which I'll also discuss briefly in a minute. So there are, in fact, a couple of network meta-analyses that look at this topic in part already, and the main one was done by Glenn Hazelwood, where he looked at methotrexate alone and in combination with other drugs for the treatment of rheumatoid arthritis. And there have also been a couple of network meta-analyses of biologic drugs for rheumatoid arthritis, but there's never been a global NMA of all of the available therapies for rheumatoid arthritis, and it's not yet ever been done in a living sense. So that's the challenge that lies ahead of us. And we want to turn this into a global collaborative guidelines project. So we've at the moment, Australia and New Zealand via our trials network ANZMUSC is collaborating with the Canadian Rheumatology Association, and then we are trying to create links with the American College of Rheumatology. We've got existing links with Cochrane, and then we would like to make it a global collaboration so that we essentially globalize the evidence. So we provide an ongoing, living, one-off, constantly updated summary of the evidence that all contributors will have access to, and then at a regional country-specific level, then people can make their own treatment recommendations. But we would all dip into the same evidence pool so that we don't have to continually repeat the effort of making syntheses of existing data. So we're at the protocol planning stage essentially at the moment for this living NMA, and this is what we plan to do briefly. So this will be a network meta-analysis of randomised controlled trials of adults with rheumatoid arthritis, and it will be comparing any of the existing disease-modifying drugs, and as we enter living mode, that will also include novel disease-modifying drugs, and that is one of the challenges for us. Another challenge is to agree on a global set of outcomes, and that's a whole other discussion, which I won't go into right now. And then essentially we're going to sort these trials into three subgroups based on the subtle variations in the population. So we will essentially have three PICOs embedded within the same network, and that will be patients who've never been exposed to DMARDs, patients who've failed to respond to methotrexate, which is the most commonly used first-line treatment, and then patients who've failed to respond to biologic drugs. We plan at the moment to use Covidence to do all of our data extraction and risk of bias, and in fact that will be the platform on which we host all of the data in the initial phase. We'll then do inside the network meta-analysis, our data synthesis will use the method that Glenn used for his existing NMA, which is a fairly standard Bayesian network meta-analysis, with fairly standard statistical techniques to interrogate consistency and heterogeneity. One of the things that we're trying to do, which we think is a bit novel and useful, is that there are two. One of the issues, and Anna alluded to this, is in how do we manage the workload on a project of this size, and using automation and using Cochrane Crowd are two ways that we can handle that. So we've in fact enlisted the help of Cochrane Crowd in the first instance to do our initial title and abstract screen and sorting into RCTs. And then what we're going to do is a modified version of that, where we're going to train a group of probably rheumatology trainees or young keen rheumatologists to then do the PICO annotation and sorting for us inside the Cochrane Crowd platform. And so this will be the sort of algorithm that we'll train them to follow, so that we can quickly and easily sort the identified studies by PICO and do the same thing as new ones come in the future. So this will be the sort of thing that it'll look like. And in fact, we've done the initial screen, and this went through the standard Cochrane Crowd. And as always, it's impressively fast and effective, Cochrane Crowd. And we've done it actually for not just for rheumatoid arthritis, but for a related condition, spondyloarthritis. And the crowd was able to sort on RCTs and the diagnosis. And we've identified about approximately 10,000 citations, which we will now move into the second phase of PICO sorting. We are now in the process of developing data extraction forms inside Covidence, and again we will use our trained set of crowd participants to help us to do the data extraction. So this is how the training will work. So we are in the process at the moment of recruiting some keen young Canadian and Australian early career rheumatologists and trainees, and within the next week or so, we hope, we will actually we will initiate the training process for them. One of the challenges is working out exactly how we reward that effort. We think that it's a fantastic training opportunity for them, and they'll be listed as collaborators. But there's also the opportunity that if they are a highly prolific crowd contributor, that there is a possibility to progress through the chain of contribution to the work, all the way up to eventually being an author if necessary. And we're going to try and train them through another Cochrane tool called Cochrane Classmate. In terms of automations, Glenn in Canada has got a PhD student who's going to work specifically on some of our automations. And essentially, his role is to try to take the data that gets extracted from Covidence and automate the movement of that data out of the data repository in Covidence and then straight into presumably into using RevMan, and some of the technology behind this is yet to be determined, so that we end up automatically populating our great evidence tables and summary of findings tables. But that's going to be quite a large body of work in itself. We hope, though, that in the future that might mean that as new data comes in, data is extracted by the crowd, and then it automatically starts repopulating our summary findings table so that we can actually interpret it and do our quality appraisal as well. So this work is in its early stages, and it's raised quite a large number of challenges and considerations already, and I think Anna's going to talk to some of these in a moment, but there's lots that we're thinking about at the moment. In particular, we're thinking about how do we do ongoing surveillance for drugs that may not exist yet and therefore may not have names yet? How often do we need to update our search strategies? And how do we find drugs that have new names that we don't anticipate in advance? There are lots of questions around what we do when new data enters the network and changes the configuration of the network. We've got some challenges around how we continue to use these machine and human assistants in the future. And one possibility may be that if we start seeing fatigue in the crowd, that we can actually use the output from the crowd tasks to train machines to do some of the automation tools into the future. But the technology really needs to catch up with that to some extent. And then what are in the future, as we're in living mode, what are the tasks that are best done by machines and what are the tasks that are best done by humans? When it comes to humans, one of the big questions is how do we keep our workforce going? This is a big project and we don't anticipate it ending anytime soon. So how do we keep a sort of corporate knowledge through this body of work as people come and go through the workforce over the years? And then when it comes to the living network meta-analysis, are there specific areas that might be amenable to automation that hasn't been considered yet? As with any living systematic review, we need to make a number of decisions in advance about how we handle new evidence, what are our rules around republishing, how frequently we search, and what would be the situation in which we would move out of living mode. And also how often do we update our search and our other methods. And finally, we want this to be a global effort, and we want this to be the canonical global repository of data on treatments for rheumatoid arthritis. And in fact, I really loved Anna's concept of having a living community for a particular disease, and that's exactly what we want to do. But we need to have a think about where those data live, how they're protected, and who owns them and who has access to them in the future. So there are some governance issues that we're continuing to work through as well. So that's all that we're doing at the moment. We've got a lot of work in front of us, and it's really great to have the opportunity to talk through these things in this setting. So thank you for the opportunity. Here's the team that's working on it, and we expect that team to grow and grow.
Thanks, Sam. That's a fabulous presentation, and I love the fact that it's not enough to take on a living network meta-analysis. You're kind of taking on 3, and you're also building a whole lot of tech to support it. What a fantastic project. Thanks for that. There are a couple of questions of just clarification here. David Tunnicliffe's asking Sam that just to clarify that the grade assessment will not be automated, and I understand that's correct, isn't it? The grade assessment itself won't be.
No, the grade assessment itself won't be, but if we can populate the tables as much as possible, then we think that makes it easier then for humans to do what humans do best.
Perfect. Paolo, I see there you've also asked a question around asking for more information about the use of machines to perform the literature search. That's a great topic. In fact, it's a fabulous topic for a webinar and be our next webinar topic. I don't think we have the time to do it justice right now. I imagine, Sam, that you're using the machine learning classifiers and so on being developed by James Thomas at UCL with colleagues. Is that correct?
Yep.
Yeah, great. And Paolo, do make sure you sign up for our next webinar to find out more about how those tools are working. I've had a couple of people just ask whether they can have slides afterwards. I understand our presenters are happy to share their slides, and the session will also be recorded, so you can re-listen to perhaps at a slightly slower speed if you want to make sure you've got all the details. So yes, we'll definitely make those available. Now, there are some great questions that are going to be important for us to discuss, and I know that Sam, you've already shared some of your questions with Anna. So what I might do now is, Anna, ask if you're happy to address some of Sam's questions, and then we'll open the floor to questions from the rest of the attendees. So yeah, sure. Anna, perhaps you might read Sam's question and then give us a brief response. That'd be fabulous.
Okay. So how do we handle the situation in which a new trial might mean that a trial that was previously excluded due to lack of any direct evidence links now eligible due to a common comparator? So I think this is quite straightforward because if a trial is disconnected to the rest of the network, this doesn't mean that it should be excluded from the systematic review. So the trial, of course, cannot be added in the network meta-analysis because it cannot be analyzed with the other trials, but it should be included in the systematic review and in the data set. So when a new trial comes and connects this trial with the rest of the network, directly we can use all the data set to analyze the data. So this is, you can consider it as the same situation when you have a trial that does not report one outcome. So this study is still in the systematic review, although it is not in the analysis. And what I always recommend to people, so when I collaborate with clinicians and they come to me with their data, and usually they have like 3-4 different data sets, one for the risk of bias, one for the outcomes, one for the characteristics of the studies. I always request one single data set with everything. So once you have one data set with everything, and then you add the new trials in the same data set, and you always start from this data set. So all the analyses then are straightforward.
Great.
Think I think I addressed this question.
That's a beautiful practical response. Thanks, Anna.
Okay, so the next question, it's about the a priori decisions, when to incorporate new evidence, when to republish, the results, the search frequency, etc. I think this is a question that cannot be answered in general for limited systematic reviews and limited network meta-analysis because it depends on the medical field. So, for example, there are fields where there are 10 new trials every month, and there are fields that there is maybe only one new trial every 3 months. So we cannot have the same updating rate in the two living network meta-analysis. So, and I think this is something that should be discussed within the research community and the research and the core team of the research team. So now in terms of publishing, I think, well, to my view, I think it's worth republishing the results if there is an important change. So if the new results just confirm the previous results, I think it doesn't worth to publish again. And I'm not sure if it is easy also to convince the journals to republish the results. So we could just upload somewhere the results online and republish when there is indeed something interesting to say.
I think there's still lots of open questions around publication models for these types of reviews, whether they're network meta-analyses or living systematic reviews more generally. Perhaps just a linked question from David Tunnicliffe, Anna. He's asking, what sort of criteria are you using to decide which topics are ideal for living network meta-analyses? How do you choose what's an appropriate topic for an LNMA?
Well, I have to say I'm not the person who decides that, because this is mainly something to discuss between the clinical investigators who know the field better. I am more I work more on the methodological and statistical part.
No problem.
So I think it's this depends on how fast the field evolves, I would say.
Yes, and I think Sam's also made a number of comments about why he thinks the field that you've chosen, Sam, is particularly useful for this, and they're probably similar kinds of topics that are appropriate for LNMAs, whether they're important for decision making, quickly moving field, and multiple potential interventions or treatments.
Yeah, exactly.
Great. Okay, thank you.
Okay, so where to host our data to future-proof the current network, prevent the need for duplication of work in the future? Well, again, I think this is something that we're still trying to figure out how it's best to organize all that. Well, I don't know if Confidence is the best data repository. It might be. And I know that many people are using also Medplay recently, and they're quite satisfied. So I think, again, this depends on the investigator. So which software they're more familiar with, and whether what kind of resources they have.
And it feels to me too that this is an area where tools are evolving and developing as methods are for these reviews. So it's likely to be movement over the next few years.
So what we try to do is to use this website that I showed at the end in order to put everything there. But then, of course, we need people to maintain the data and everything. So we need a lot of resources for that.
Great. Okay. I think I suspect there's one or two more questions from Sam, and then we'll open the floor to other discussants. So if you're attending and you've got questions, please do put them in the questions box, and I'll ask Sam and Anna to answer them. Anna, perhaps this question, what are the appropriate methods for error adjustment in repeated analyses when in living mode?
Yeah, well, this is, I think there are two schools of people with respect to that. So there are people that they believe that meta-analysis and network meta-analysis should not be seen as randomized trials, and so there's no need for error adjustment. And there are people that believe that error adjustment is necessary. So, so my view is that, and many other people's view is that error adjustment is necessary when we want to define stopping rules. So when we want to define rules that will say, so well, when the evidence is conclusive for these comparisons, then we will stop the living network meta-analysis. So if we only just take the evidence that comes up and we accumulate it, and we don't do any statements like that, like whether the evidence is conclusive, etc., then probably it's not necessary to consider error adjustment, because we don't do any test in such a case. So we just obtain relative effects and confidence intervals and probably the ranking. So we don't do any test. But if we want to define a priori that when we will consider that evidence is conclusive, then we need to do some error adjustments, and we need to define all of these at the protocol stage. And for people that are interested to that, I think there are several papers discussing error adjustment for simple meta-analysis. For network meta-analysis, to my knowledge, there is only one paper by Adriani Nikolakopoulou at the Statistical Methods of Medical Research. And the title is Continuously Updated Network Meta-Analysis and Statistical Monitoring for Timely Decision Making. And she suggests there methods how to define how to do statistical monitoring for network meta-analysis. What is to date the limitation of these methods is that they consider one comparison at a time, and still we haven't developed methods for considering multiple comparisons jointly. So how to define, how to do statistical monitoring for multiple comparisons.
Great. Thank you, Anna. And probably worth just flagging here that the Cochrane Scientific Board has recently released guidance suggesting that error adjustments are not required for repeated analyses in living systematic reviews for exactly the reasons that you outlined. If they're not making a priority judgments about when to cease, then it's a different kind of conceptual model. And we can provide a link to both the paper you've just referenced and also that advice from the scientific committee in the materials from this webinar. Okay, there are a couple of additional questions that'd be great to get your thoughts on. First, Sam, I overlooked a question earlier from David. He just was a clarification around the PICOs that the 3 PICOs that you're including in your LNMA, and just wondering whether they'll be undertaken as separate networks.
Yes, we're still just working through that a bit, but the idea is, yes, they'll be separate networks. So it's almost 3 parallel NMAs, but with a convergent protocol in various parts. So we think that's how we're going to do it, but we haven't 100% decided yet.
Great, thank you. I know, Anna, that a question that's dear to your heart is around use of data other than that from RCTs in these types of analyses, and Paolo's asking about, what your thoughts are in terms of with respect to the use of RCT versus observational studies in NMA, and whether you would recommend people stick to only RCTs or include broader study types.
Well, I think again it depends. It depends on the field. So if it is a field that there are many good quality RCT studies and they are well connected, the network is quite dense. There is not a lot of heterogeneity, and transitivity seems to be plausible. So if we have such a network, it might be sufficient to focus on the randomized controlled trials. But if there is a field where there are few RCTs and there are many interventions have been evaluated in non-randomized studies, or there are concerns about the RCTs and whether they can be whether their results are can be used for a broader population, etc. In such a case, I think it makes sense to consider including also other types of studies and other data.
Okay, that's a useful guide. Thank you. There's a question here, Anna, around the amount of full-time equivalent staff that are involved on this type of dedicated to this type of work. It was great to see that slide you had with the body of work that was required to undertake the original network meta-analysis and then the updates. And also it's been useful to have you refer to the kind of the broadness of the collaboration that's useful for this type of work. But can you give us a sense of the amount of people time that's involved in living network meta-analyses in your experience?
I have to say, I don't have this data. I can say from my part, from the analysis part, that well, for sure, I would say, for example, for the first update for the lung cancer example, my time in terms of analysis was, let's say, 70% of the initial time, because I had most of my codes were ready and I just had to run them again. So, yeah, this is my experience. So in terms of the systematic review part, Maybe Sam is more appropriate to give, to give an idea.
No problem. I think this is an area in which we're all trying to work out how much work is involved in maintaining these into the future. Sam, any comments or thoughts from you?
I think it's really hard to predict, actually, and it's a little bit scary to think about it sometimes. So, but I don't know, and I guess that's why we're really keen to try to put in as many systems in place in terms of not just community, but also automations to make sure that we don't get ourselves in a situation where we can't complete the work that we intend to do. So it's a big challenge.
Yeah, great. It's that was certainly our experience from the pilot living systematic reviews that we evaluated both within Cochrane and out, that the amount of work varied so incredibly widely depending on the breadth of the clinical question and how quickly new research was being published, and how quickly the reviews were being updated and republished, that it's very difficult to make any generalisations at this point, at least, about the workload that's involved. I'm very aware of the time, and I want to make sure that we finish on time. We have a quick question here from David about how you would determine when old trials would be excluded, and whether the indirect evidence they would provide would still be useful. Anna, do you have a quick response to that before we wrap up?
Well, this is one of the areas that we are working, and I don't have a quick question, but I hope I will have in the next few months.
Great. Well, we look forward to having you back at some time in the future to answer that question for us. Thank you very much, Anna. My huge thanks to both our presenters today. I've found that fascinating, and I'm sure that you have too, and to all our questioners. That's really useful. This was a webinar presented on behalf of the Living Evidence Network, which now includes more than 230 members. If you're not a member and you'd like to join up, please email us today at the email address that's on your screen there, lsr@cochrane.org. And as I flagged, we've got more webinars coming over the next few months. We'll have one on enabling technologies, and then another one on publication of living evidence. So I look forward to having you join me then. In the meantime, best of luck with all your living evidence work. And again, my thanks to the presenters. That's been a fantastic session. Thank you all. Thanks very much, and enjoy the rest of your day.